यस दिनेश जी, आपण चालू करते हैं.
Good evening to
You are
everyone
mute.
once again. Sir,
नहीं नहीं
sir, audible?
नहीं, हम लोग होस्ट कर रहे हैं.
क्या मेरी आवाज आ रही है सर?
Hello, welcome Dr. Rajesh Pavaiya.
Very good evening, sir. Good evening, all of you.
नमस्ते.
Sir,
Good evening.
Good evening, all.
Very good.
Should I start?
Dr. Dinesh,
Sir,
some
start, sir?
problem in your audio.
sir, अभी आ रही है आवाज?
Yes, now it is clear.
Yes,
Yes,
sir.
absolutely.
So, very good evening to all the respected MPIAPians or faculty. On behalf of MPIAP, I, Dr. Dinesh Mackley, warmly welcome you, all of you, for today's MPIAP online CME. Today's a specific topic on that vaccine dialogue with an important discussion on dengue vaccine, pneumococcal vaccine, influenza vaccine, rabies vaccine, and one more vaccine. So
HPV
HPV vaccine. So HPV vaccine. So we have our expert faculty, Dr. Chetan Trivedi, who is infectious disease expert and vaccinology expert. This time that CMA is hosted by IAP Chipri branch with President Sir, SR Ahmed Sir, and the Secretary Rajan Pavaiya is there. And the session is moderated by Dr. S.S. Rawat sir from India. So before we start the proceeding, I would like to invite MPIB President Dr. Rajiv Singh sir to just say something regarding the CME procedure. Rajiv sir.
Thank you, Dr. Dinesh. I welcome you all to this another series of MPIAP online CME on vaccinology. And we are very fortunate that we have two stalwarts in the field of infectious disease, Dr. Chetan Trivedi and Dr. S.S. Rawat. And I thank Dr. Chetan Trivedi for accepting our invitation in spite of his busy schedule. So thank you, Dr. Chetan. As a general pediatrician, we always have a dilemma about the vaccines. We have learned so much in different conferences, but still some confusion remains in our mind. So today, I hope that all the confusions will be clear by these two stalwarts on infectious disease. And I thank Dr. Nisar Ahmed sir also for accepting our request to host this CME on vaccinology. Hope everybody will enjoy this session. So now I hand over to Dr. Dinesh Meklia.
Thank you, sir, for your kind words. I would like to invite President IAP Sipri branch, Dr. Nisar Ahmed sir, to say about your branch and Nisar sir.
Thank you, sir. And good evening to everybody.
Keep yourself unmuted.
Some echo is going on. Respected President Dr. Rajiv Sanghvi sir, our beloved Secretary Dr. Dinesh Mekli sir, and honored guest speaker Dr. Chetan Trivedi sir, our honored guest moderator Dr. Sanjeev Singh Rawat sir, and all the esteemed members and dear friends. I welcome you all on behalf of IAP branch of Shivpuri Academy of Pediatrics. Shivpuri is a very beautiful city. It is a city of Lord Shiva, and it's a great moment for you people to host this online CME on vaccinology. A word about Shivpuri, that Shivpuri used to be the capital of the Sindhiyas before the freedom, before 1947. There are numerous places to visit Shupri. Mostly Sindhya Chhatris of Sindhya, which are made of marbles, and great fort of Narvar, and a great fortress of Survaya ki Gadi. And apart from this, Shupri is apart from this, Shupri is known for its Madhav National Park, which is the 58th park of the country and 9th in the MP for the Tiger Reserve. So it's a very beautiful city. There are numerous places worth seeing. I welcome you all. Whenever you get time, come to the Shupri. We are here to welcome you. Thanks a lot. Thanks, sir, for giving us opportunity to host this online CME. Thanks to our president, Dr. Rajiv Sanghvi, sir, and secretary, Dr. Dinesh Meklis. Thanks a lot. Jai IAP, Jai Hind.
Thank you, Dr. Nisar Ahmed, sir.
Thanks.
Would like to invite our expert, Dr. Rawat, sir, to start the proceeding.
Thank you, Dr. Dinesh. Thank you, Dr. Rajiv, Dr. Nisar, and all the people who are there on board today evening. We'll start the CME quickly. Some ground rules. Today there would not be any presentation, and Dr. Chetan sir is an ID expert and is a vaccine expert, and I'll ask the question to Dr. Chetan, and he would be answering it. My request to all the people who are there on board today. Just type your question. If anything you want to ask, type your question in the chat box, and we'll try to take that. Request all of you to please mute, because talking in between will disturb us. So it is in your interest that please all of you mute. If you want to ask any question, you can please ask in the chat box. My request to Chetan is that we all are general preparation. So my request to you is that please give straight, direct answers. Like we just try to give them very clear guidelines rather than trying to give them multiple options. So my request to you is that based upon your experience and the best available evidence, please give a very clear answer so that people, when they go back, they have got a very clear idea what thing they have to do. So we will start with a new vaccine, which is now new kid on the block, dengue vaccine. As you all know, permission has been granted from the DGCI to market dengue vaccine in India. Now, before you start using this vaccine, first question to Dr. Chetan would be, do we need dengue vaccine in India? Like, what are the guidelines, what are the WHO guidelines, which country should use dengue vaccine? Like, we are having different states with different incidents of dengue. So what are the exact guidelines for use of dengue vaccine in any country?
रावत सर, मैं सबको म्यूट कर रहा हूँ सर, आप एक बार अपने आप को अनम्यूट कर लेना.
Yes.
Lot of interruption is going on.
Yes, please.
दिनेश, आपको क्या करना पड़ेगा इन बिटवीन
Sir.
जो आवाज आ रही है उसको आप म्यूट करते जाना, because people they are joining, no, they are not aware that they are on, so many by mistake they are doing it, so you can just, because you are
Yeah, sure.
listening, no? Yeah. Anyways, thank you so much, Dr. Rawat sir, for this wonderful opportunity to interact with you. And I can see many Diggajis on the this forum. I think I saw Dr. Nagesh, Dr. Preeti Galagili, and so many. I'm not able to see now, but thank you so much, everyone, for joining. Now, the first question from Rawat sir is, does India need a dengue vaccine? I think as a general pediatrician, we all know the answer, because we are seeing cases day in and day out. So I think any disease which we are seeing, definitely it is going to be a sizable when it is coming to the nation. Now, when we say it is there, then we should be knowing what is seroprevalence of that particular disease. WHO may give guidance for the implementation of the vaccine in the national immunization schedule, but they will definitely give some approval for the usage of individual patient or person. Now, as far as the India is concerned, if you see it in last 20 years data, so it was 5 lakh cases in say 2000. Now it has come to 20 lakhs. 50 lakhs, 5 to 50, so 10-fold increase in numbers. Now, or not only that, but we know that what are vectors? Vectors is this our mosquitoes. And mosquitoes have been rampant nowadays because of the, more urbanization and our lifestyle have changed. So that's why the mosquitoes have been there. And the atmosphere is suitable in our country because ours is being a temperate country. We have a good atmosphere for this particular vector to grow. And because of that, we have sizable incidence of this particular disease. Now, not only disease is there, it's symptomatic infection, asymptomatic infection, but disease is known to cause complications. And if you say 1 in 4, 5, they can get severe dengue. And, many a times what happens, symptomatic, almost maybe it is 1%, but 1% is one out of 100. So there are all the chances that this dengue, which our patient is having, may go for the severe dengue. And there can be a real difficult situation because we have seen uh, dengue with shock or severe dengue patients very difficult to manage because at one time there is a fluid which is being accumulated and one side there is a renal shutdown. So in this, looking at this severity of dengue and mortality also associated with that, dengue vaccine is required because as such we know that we can deal with this problem maybe by vector control and everything, but we know that that is not enough because of the vector itself, because vector is very special. This Aedes aegypti, the mosquito, they are, daytime biting mosquito. They can fly maybe 1 to 2 meters only. So that has been, we are very close to their their targets. And second thing is these mosquitoes are so specific. They keep on biting. It is not only one bite. They keep on biting. So there are chances that we can get an infection. So looking at everything, vector, our epidemiology, and the disease burden itself, I think we know that dengue vaccine is very important. We should have it. So yes, India needs the dengue. And if you see now the numbers, so 50% of our our population is seropositive. Matlab they already have the dengue. So that's why the incidence and prevalence is very high.
Okay, so I think there is no doubt about it that dengue vaccine would be used in India and probably it will be used across India. And we are just waiting for the guidelines from Government of India and from IP how we should use the vaccine. So you just tell me in brief what is this vaccine, because this is a new vaccine. People are interested to know. So just explain in brief what is this dengue Qdenga.
I'll just would like to share my screen first because it will be easy for me to make understand.
Okay.
Because dengue, just a minute, let me share. Have you given me right to share? Yeah. Okay. So I think you are able to see my screen, right?
Yes.
So when we talk about dengue, we know that there are 3 vaccine candidates, right? They are available. As far as other vaccines are concerned, other than TAC 003, which has got recent approval in India by DCGI, is a Qdenga, right? But there are 2 other vaccines which are available all over the world. That is, one is Dengvaxia, which is available still only to be given because of this Dengvaxia, which caused the adverse ADE, right? So because of ADE, this has not been given to everyone, only in those countries where the seroprevalence at 9 years is more than 80%. Or suppose if you do and the seropositive patients, you can give it. So that is about Dengvaxia. Antibody dependent enhancement is a major concern for this Dengvaxia, and that's why it is not been used now. Another vaccine which is there already in Butantan, I'll be just giving brief of that. Butantan is a single dose vaccine which has been tried in Brazil. It is been given, phase 3 trials are going on. Unfortunately, they had cases of 42 cases of severe reaction because of that. So at present, the project has been kept on hold. So that is the Butantan vaccine. And third vaccine is Qdenga or TAC 003. That is a Takeda brand. Now, all these 3 vaccines are having one thing which is common, which is all 3 are live attenuated vaccine, right? And they are chimeric vaccine, right? Live attenuated vaccine means they have been attenuated to stages that didn't cause a disease. Now, for any vaccine, particularly for dengue, we should be having first that it should be, equally been effective, maybe all age group. Second thing, it should be safe. Third thing, it should be effective. And fourth, most important thing, it should be acting on all the serotypes. Because we know that dengue are having 4 serotypes, 1, 2, 3, and 4. For that matter, we should have the vaccine which covers all 4. So what is happening? This particular, I'll be talking about this only Qdenga. This particular vaccine is made on a dengue 2 backbone. Now, what is this backbone? See, if you can see this yellow line, right? So these all are the live attenuated dengue 2 serotype. Now, what they do, non-structural proteins are same because we know that dengue virus having the structural portion. This is C, pre-membrane and envelope. This is structure. This is non-structural protein. And there are different NS1, NS2, NS3, NS4, NS5, right? Now, here what they do the chimerism. Now, what is chimerism? You must have seen the Narsimha. Narsimha it was having a lion, face of lion and the body. So there is a chimerism. So what they do, on this backbone of dengue 2, there is a genes which are responsible pre-membrane and envelope. They have been chimerized. Matlab they have been changed. So that's why this is a chimeric live attenuated vaccine on dengue 2 backbone. Now, why it is important to have dengue 2 backbone? Because dengue 2 is most common after 2012. So, if the vaccine is having this particular dengue 2 virus backbone, it will be effective against dengue 2. But at the same time, we are having all 4 serotypes working. So, it is a tetravalent vaccine. So, that is in nutshell about this Q dengue which is available, which is made of the dengue 2 backbone with all the serotypes which have been chimerized. This is in nutshell.
Thank you. Thank Dr. Chetan. So again, to just repeat what you have said, dengue vaccine is a quadrivalent vaccine which contains all 4 viruses, DEN 1, 2, 3, 4. But the basic backbone is DEN 2. And other viruses, DEN 1, 3, and 4, they are there, but they have got only their envelopes and the genetic core is from DEN 2 virus and the PRM and E proteins of other 3 viruses they are made into that. So basically, it is going to protect against all 4 viruses, but mainly it is against DEN 2. Sir, now we are concerned with what is the immunogenicity and efficacy, like what are the field trials we say, because when we start using the vaccine, the patient will ask how good is the vaccine and how it will protect us. So what are the field trials telling what is the immunogenicity and efficacy of these vaccines?
So whenever this comes into comparison, so we should have a safety trial, we should have immunogenicity trial, we should have efficacy trial, right? So this particular dengue vaccine is being tried, which is live attenuated tetravalent vaccine. It is a big trial, which is TIDE trial, which they are doing. A TIDE trial is almost spread over 20,000 persons. And what they found that this particular vaccine, it is studied over a period of say 4.5 years data are there. And it shows that it is immunogenic. Immunogenic means it produces the neutralizing antibody. Now, this antibody, we know that there is no correlate of protection. So, above which we can say this is going to be protective. Now, this neutralizing antibody, what they found on an average against all this serotype, it is more than 100. So, what they say is like higher the titer, better. But we don't know what is the required titer, right? So, what they found at the end of say 51 months, the titer was above 100 in against all serotypes. So that is the immunogenicity data. Now, second thing comes efficacy data, right? So when you say efficacy means what happens say after the 4.5 years. Now, efficacy is always considered what is a primary endpoint. So primary and secondary endpoint. But you decide what are you going to study once you give the vaccine. So you give the vaccine, first you try to see immunogenicity data. That means seroconversion is happening or not. So with first dose, seroconversion happens maybe 75 to 80%. With second dose, seroconversion almost 95%. So that is, so immediately you give the vaccine. After 1 month, you check the titer. It is above the 4-fold. That means it is seroconversion.
Then it's fine. Now you tell about efficacy. It is immunogenicity.
So that is immunogenicity. Now efficacy, what happens? See, there is 2 things. One is virological confirmed dengue that we will assess. So what is the efficacy data for virologically confirmed dengue? And second thing, how much it prevents the hospitalization. So when we talk about virologically confirmed dengue, 62 or 61 to 62% again VCD over 4.5 years. And same time, the hospitalization almost 84% protection. That is the efficacy data. Now, this data have been analyzed not only on this particular, say, virological confirmed dengue only, but what are the age groups? What are the serotypes? What is the seropositive or seronegative? Everything it is considered, and then ultimately this phase 3 data has been evaluated. So in general, when you say efficacy, it is 62% at 4.5 years against VCD and 82 84% against the hospitalization.
Again, what I want to repeat what you have said is that the efficacy at the end of 2 years, they have mentioned it as 80% against virally confirmed dengue, and it is 90% against hospitalization. So I think this is the main beauty of this vaccine, that this is going to prevent against severe dengue, because 90% protection in the first 2 years by a vaccine, it is absolutely great. So I think this is going to change the scene in India, and definitely we're going to see more and more use of this vaccine, and it prevent. Now, Dr. Chetan, what are the schedule? How will you use this vaccine? In what age group? In what age group it has been licensed, and how will we use it?
Now, there is one more concept, that is what is the age group licensing. Now, DCGI has given approval above 4 years. So 4 to 60 years, that is what it has been approved. So you can give 4 years onwards. There are 2 doses to be given. This is live attenuated vaccine, so it has to be given subcutaneous. 2 doses to be given, maybe 0 and 3 months. And it is 0.5 ml. It is lyophilized solution. You have to dilute with the 0.22 normal saline, and then you have to give it subcutaneously, 2 doses about 4 years of age. So that is the availability. As of now, it is not available. It will be available in these particular forms.
Okay. Now we know that we have to use two doses, and then the age group is 4 to 16 years, or say 6 to 16 years, and we'll use it. Now the patient will ask, will this vaccine protect against all dengue viruses? Because they know that there are 4 dengue viruses. So what answer you will give? Whether it will give equal protection against all viruses, or it is not protect against all viruses? What is the correct status?
So this is there the catch is, it is not that simple to start this vaccination in the practice, because this particular vaccine, we know that 4 serotypes are there, right? And there are population which is seropositive. That means those already had either symptomatic or asymptomatic infection of dengue, and they have seroconverted. So that is seropositive population, seronegative population. And we have to see which serotype has been covered. So we know that dengue, this particular Q dengue is on serotype 2 backbone. So it is going to work well against then 2. Then 1 also it is going to work better. Then 3 and then 4. In all seropositive patients, all 4 serotypes will be covered. For dengue 1 and 2, seropositive and seronegative both going to cover. Now the question remains of serotype 3 and serotype 4. Serotype 3, seropositive, again it is going to work. But serotype 4 and serotype 3, which is seronegative, we are not very sure, because this particular study is not been that much robust to give the information or give correct answer for serotype 3 seronegative and serotype 4, because during this particular study the serotype 4 was very few in number. So there the problem is now, because we have burnt our fingers with dengue vexia, because in that patient what happened, those patients were seropositive, it was fine. But if the patient was seronegative and Envexia was given, so it was acting as a second infection and was giving antibody dependent enhancement. And that was creating a more severe dengue in those who have not suffered. So that's why here we are particular serotype 3 and 4, we are a bit concerned whether it will be safe to give in seronegative also. So the data says yes, safety issue is not there, but efficacy is not been proved with the confidence. So that is a catch. Now you will come to ask the second question. Serotypes, suppose if are we aware which are the serotypes which we are having? Now India latest, I think today or tomorrow, yesterday, we had an article which showed the ICMR study, which is results have been reported, released. So ICMR did that study, and what they found that in India, there are all 4 serotypes have been found. Depending upon the zone, the north, south, east or west, they are different. But all 4 serotypes are found. On what they said, okay, 50% is serotype 2. Say serotype 3 is again 13 to 15%. Serotype 1 is around 7%. And serotype 4 is hardly any, so 1%. So now the question remains, 1 and 2 is fine. But the 3, we are not having seronegative confidence, and 4. So this is the problem what we are going to face. Now, suppose if you see this data, and if you find, suppose I am from Gujarat, So there are 30% of serotype 3 which is going to be found, right? So it will be very critical to understand which serotypes are being going to be there, because we have less data which is coming now. Gradually data is coming up. So serotype coverage and the protection has to be considered. So yes, this is going to be a concern.
So I think I'll just tell in short, you have to tell patient very clearly that this is not a 100% proof that you will be protected against dengue. First thing, because no vaccine is 100% protective. Maximum efficacy is against Den2. Like if your area is having a lot of Den2 viruses, definitely this will work beautifully, and about 90% of serious cases can prevent it. But again, against then one, again there is good data for protection, but the 3 and 4 we are very doubtful. So please don't give a blanket assurance to the patient that I am giving this vaccine and that it will take care of all the problem. All the measures like mosquito control measures, they have to go on, because if you don't take care of those things, the thing is going on to be bad. Dr. Chetan, in short, tell me what are the side effects of this vaccine and what are the precautions? In short.
Side effects as such, they are not going to be much serious side effect. No serious adverse effect will be found. Yes, of course, we have to take care of anaphylaxis, because that can happen any time. And new vaccine, if any anaphylaxis occurs, it is really a cause of concern for all of us. So that is one thing. So you have to ask them to wait for at least 15 minutes after giving the vaccine. Otherwise, antibody dependent enhancement, that is what was concerned. I think it is not there with this Q dengue. So that is something reassuring. But effect, as you said rightly, you can't be sure that is 100% effective. No, you can't be sure. Yes, it is good to have serotype 1 and 2 and seropositive. Definitely it is going to work. So those who already had dengue previously, if you give it, definitely you are going to get a better outcome.
So it's a live vaccine. It cannot be given in pregnancy. It cannot be given in immunocompromised. Not to be
Immunocompromised
given in
pregnancy.
lactating women.
So in general, what are the contraindication or precaution for contraindication? So immunocompromised, because live attenuated vaccine cannot be given. So that is very clear. You just follow MMR or chickenpox, whatever we are following, it cannot be given.
So I just like to add one thing, that when it was used in Brazil, there were 16 cases of anaphylaxis. So even the WHO has clearly told that there is some risk of anaphylaxis. So those who are using this vaccine in the clinic, please ask the patient to stay back for at least for 15 to 20 minutes and keep your clinic ready to deal with any anaphylaxis, because cases of anaphylaxis they have been reported. So first thing probably you have to see for anaphylaxis. And there were some cases of serious dengue by DEN3, because there are some reports, although they were not statistically significant, but after using this TATAC3 vaccine, there were some cases of serious dengue 3. So again, you should be very careful that in case if your area has got more amount of DEN3, probably chances of some antibody dependent enhancers can occur against DEN3, and although it is not certainly significant, but you must be careful. So I think Dr. Chetan, you have please.
Yeah. One more thing, because when you say age of 4 years to 60 years licensing is there, but WHO is recommended from 6 years onwards. Now there is a very interesting discussion between these 4 to 6 years bracket, right? If you see the data, what that is been found from this studies, 4 to 5 years, or this 4 to 5 years and say 11 months, this particular age group is having a less efficacy data if you compare with 6 to 11, if you compare to 12 to 18 years. So 4 to 6 years is still, WHO is also putting a question mark, because they found the efficacy is less, and because that particular serotype 3 was then 3 was creating problem there. So that's why they are not very positive about 4 to 6 years age group, and that's why they have told you give it after 6 years. But yes, you can give it 4 years and onward. That is a licensing age, but this is just a cause of precaution which WHO is given.
So thank you. I think we have discussed dengue vaccine too quite in detail regarding what general practitioners should know. Let us hope that more guidelines they come from IP and government of India, and then we'll be using, as the vaccine is launched in India, then probably we'll be using it more. So after dengue, we'll take another vaccine which is very important, rabies vaccine, because rabies post-exposure prophylaxis is life-saving. So you should have a very clear idea in which way, how we are going to treat these children who are exposed to wild animals. My first question, Dr. Chetan, please be very short and brief because we have got 3-4 vaccines to be discussed more. So, which are the animals which are where we need to give them post-exposure prophylaxis, and where animals which we do not need?
So there are, see, most of common cause of this rabies is the dogs. You know that. Almost 95% human rabies we have been caused by dogs. But then you consider dogs, cats, fox, jackals, donkey, monkey, camel. Then you can have raccoons or you can have bats also in certain caves like monkey, donkey. So these all are animals which can cause this rabies. Now, those are certain animals where we are concerned. Typically, we get a call for, rat bite. We got turtle bite, or you have a squirrel bite. Now, these are
Rat,
the animals.
rat bite.
Rat. First, I told rat bite, turtle bite, even lizards. So many a times the people they ask, and turtles. So these particular animals they don't transmit rabies. There are anecdotal one or two one case maybe of squirrel causing that thing, but otherwise in general it doesn't require the treatment, rather anti-rabies prophylaxis, vaccination. These are the animals, but otherwise what I said initially that are even rabbits. Rabbits also bite, but that doesn't require rabies. So
Thank you.
rodents, rabbits, snakes, lizards, squirrels, no rabies vaccine.
Okay. So now again, the practitioner, they are not clear in which patient you should have to use rabies immunoglobulin. They are very clear about vaccine. They'll attach vaccine. But what I've seen even today, that that doctors are not very clear when you have to use immunoglobulin. Please give very clear answer when you have to use rabies immunoglobulin.
See, simple. If you see a bite where there is a blood, then you give the anti-rabies vaccine along with monoclonal antibody or immunoglobulin. So whether you remember category or not, we know because category 1 is just touching and leaking. Category 2 is that there is scratch but there is no blood. And category 3 is a scratch with the blood, right? So when you see drop of blood, it becomes category 3 and there is a necessity to infiltrate monoclonal antibody or immunoglobulin along with the complete course of anti-rabies vaccine. So simple as that.
Yes. So I think this message should be go very clear. All grade 3 bites in an immunocompetent person will require rabies immunoglobulin. So whenever you see blood in the wound, that requires immunoglobulin. Although if the child is immunocompromised, then definitely even in class 2 bite you have to use immunoglobulin. But most cases, if you see blood, you have to use immunoglobulin. So I think be very clear. Now this schedule, now there are two schedules which are going on, intradermal versus intramuscular. So in our practice, we should practice intradermal or we should use intramuscular.
So we are not allowed to practice intradermal. Not just because we don't know how to give intradermal, because we are also master of giving the BCG. So we are almost well acquainted with that. But what the government says, because intradermal route is to save the dose, right? It is dose sparing thing. So in our practice, we don't have that many patients. So we can't give it intradermal. So in general, for practicing pediatrician, it is only and only IM route to be given. No, when you send it to government sector or corporation, they give intradermal.
So
Both are equally effective. Both are equally effective. Nothing. Even if you want to shift, many a times what happens, one dose been given, it's a government, patient comes to us, you continue with intramuscular. That's fine. Absolutely interchangeability is allowed.
Okay. One WHO recent guideline, they said that you require only 4 doses in post exposure, like you give for 0, 3, 7, and 14. Whereas the older schedule was 0, 3, 7, 14, and 28. What we should follow? What does ECVIP say? We should follow 4 doses or 5 doses? Clear answer.
So why it has come first? Because WHO said that 4 doses are enough, because after giving 4 doses, if you give fifth dose, it doesn't have any incremental value in the protection against the rabies. So there is a no death which has occurred after the fourth dose, between fourth and fifth dose. That's why WHO said, okay, fine, we don't require. But when you know, okay, that WHO recommendation comes for the dose sparing thing, they want to save the dosages. So that was one thing. Now, so WHO recommended 4, so ACVIP last year converted to following the WHO. So they said post-exposure prophylaxis, 4 doses is enough. But now what happened? NCDC, which is our body, national body, which has still continued recommending 5 dosages. Now what happens? Then last 2 years we were having so much of discussion, 4 or 5, 4 or 5. The people were getting confused. So then ACVF decided let it be in synchrony with NCDC, our body, and we continue with 5 doses. So though 4 doses are enough, but I think we should practice 5 doses as of now. So post-exposure prophylaxis, 5 dose intramuscular 0, 3, 7, 14, 21, and 28. Pre-exposure, again, there is no mention. So I think we can continue with 2 dose 0 and 7. Though previous was 0, 7 and NCDC, our this one, national body was saying 0, 7 and 21. I think pre-exposure 2 doses is fine, 2 or 3, but for post-exposure, we should go for 5 doses.
Thank you. So very clear. We have to use 5 doses for post exposure and 3 doses for pre-exposure. Very clear. Now the requirement of rabies immunoglobulin. Now standardly now we are using more and more of monoclonal antibodies. For example, a commonly available brand is rabies shield. The dose is 3.3 unit per kg. Now the problem arises that if it is a very small bite, like for example, if it is a bite just on the tip of finger, and it is a class 3 bite, and he's an adult person. So a child or an adolescent of suppose 80 kg, if you calculate the dose, it is 18 to 3.3, and he has got a very small bite at the tip of the finger. How will you do? Like there is a big amount of immunoglobulin which I've calculated. How will you manage it?
So first thing, whenever we have a patient who has been bitten by any suspected rabid animal, wash the wound thoroughly under tap water for 15 minutes because that will remove almost 90% of your viral load. So that is very important. We should not forget. You may use antiseptic betadine or whatever and you clean it, or soap water is fine. Properly rush it. There are people who are telling that can we just use a jet to clear the thing? No, we should not use a jet because it ultimately damages the tissue and virus may enter inside. So virus ultimately should not lead to neural endings, right? So that is one thing. Now, the question was that if there is a wound size which is small, and according to weight, because we know that monoclonal antibody which we are using very commonly, 3.3 international units per kg. Now that 1 ml contains 40 international units, right? And if you require maybe hardly say 0.5 ml, and the dose is coming to 100 international units, how will you manage? You won't give 2.5 ml. So just infiltrate. See, once again, infiltrate. Monoclonal antibody or immunoglobulin never to be given intramuscularly. That those gone are the days we were using that intramuscular route. Always infiltrate in the wound in such a way that you go out of the wound and then infiltrate, try to ooze from the wound. Now this technique is important. Now, if your requirement of the dose is more, but the wound is small, you just infiltrate as much as you can. And then the question will come, what about rest, which has been, excess? Don't give intramuscular. No need to, because as such is not going to work even if you give intramuscularly. That means you infiltrate as much as is required. There is, suppose if you are saying it is a small wound, if it is large wound and the dose is less, what I can do? I can dilute with normal saline and make it more volume and give it. Dilution up to say 10, 15, 100 times is also allowed. Now, there is one nice, formula which has been derived by, I think, Anurag Agarwal and team. What they have found is what amount is required. Say, what they have said is depending upon length of the wound, 0.75 in ml per centimeter. That is roughly which has been required. So, and if you say, suppose you have a bigger wound, so 3.8, 3.18 multiplied by your centimeters per centimeter square. That is a dose that they have calculated. This is a formula which is they have derived, and that you have to follow. But as far as we are concerned, if the wound is big enough, dilute it, use as much as possible, small, infiltrate as much as possible. That's all.
So I think you have made a very important point that first local treatment is very important. If you have to clean properly, apply, because that will decrease the load by 50%. So that is extremely important. Sir, please don't miss that step. And
50 to 90%, sir.
50%
Up to
of the viral
90%.
load. Yes.
Yeah.
So and second thing, don't create compartment syndrome. If you have a injury at the tip of the finger. You cannot inject 5 ml there. So you will create a compartment syndrome. So inject only that much amount which will not create compartment syndrome, and you don't need to give remaining by intramuscular. If it is a small wound, give only infiltrate in that particular area, and then that is enough. Don't give anything intramuscular. So then the next question is that a child has received a complete pre-exposure or post-exposure prophylaxis, he is fully protected. Now he gets a rebite. How do you manage that? Like for example, he gets a rebite after 1 month, or he gets a rebite after say 4 months. So how will you manage that?
So this is called re-exposure prophylaxis. One was pre-exposure prophylaxis before the bite. Second is post-exposure, you give it. And third one is, suppose patient has received pre-exposure prophylaxis or post-exposure prophylaxis, and beyond 3 months, if the person gets bitten by any dog, rabid or suspected rabid dog, you have to just give re-exposure prophylaxis. That is 2 doses, day 0 and day 3, along with wound care. These patients who have received pre or post exposure, they don't require monoclonal antibody or immunoglobulin anytime. Now, suppose if it is there, suppose it has finished the pre-exposure or post-exposure, and within 3 months the bite has occurred, then nothing doing other than wound prophylaxis, wound cleaning, right? So that is very clear. So those who have received pre or post-exposure more than 3 months, up to any time. So it is not that after 5 years, 10 years, 15 years also, you just give 2 doses, no immunoglobulin. Because once we have given vaccine, antibodies already been developed. So if you give the monoclonal antibody, it will not work.
Okay, so I think it is very clear. If only 3 months have elapsed, don't do anything. More than 3 months, give only 2 doses. You don't give RIGs, give only once in lifetime. You don't give any RIGs. Achha, very important thing. Till how long you can give immunoglobulin? Like for example, a child has come to today and you are given the vaccine. He doesn't have money to purchase immunoglobulin. Till how long you can give that immunoglobulin?
So suppose they have got wound today, and they are coming after 10 days. Even at 10 days of the wound, that will become your 0 day.
No,
So
no, no,
you
no,
give.
no, 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 no,
I,
no,
I,
no, no,
I,
doctor.
I understand. I'm just telling you, I understand. So that 10 days, 0 dose, you give monoclonal antibody, infiltration, as well as a rabies vaccine. Now you have given started vaccination, day 0. Now immunoglobulin was not available or monoclonal antibody was not available. Till 7 days, you can give infiltrate monoclonal antibody or immunoglobulin in the wound. But if it is more than 7 days, there is no point in infiltrating the wound with the monoclonal antibody or immunoglobulin.
So
Because by
very
that
clear.
time,
Good, very good.
So Dr. Chetan, it is very clear. If you have more than 7 days have gone after the first dose, you don't give RIG. RIG is given less than 7 days after first dose. After that, because if you give RIG, it will interfere with the vaccine take and vaccine efficacy. So you don't give after 7 days. Now we commonly see vaccine defaulters. Like you have tell the schedule as 037. He has taken first at 0 day and now he comes at 5th day. So that's why I forgot. Now, what to do?
I think we should just restart the vaccination. Resume the vaccination, not restart. So from wherever it has stopped, you start it, counter days, and keep on giving it. So no worries about it. You have to continue the same schedule and follow it up. That's all. As simple as that.
So
No,
I
sir,
think
zero. If patient is 0 and 5, second dose, the third dose will
please,
be on the 7th day or from the second day after 7 days.
Second, after the same schedule, same gap, you have to keep it.
Now,
But
0
there
days,
is
037.
yeah, that is one clue, the clause, because first 10 days vaccination is very important. So 037 are important days. So if the patient is given at 0 day and patient comes for that second dose, maybe say at 7 days, then you try to give the next dose after 2 days. So finish the dose in 3 doses in 10 days. And then you can keep whatever, say suppose 7 days, 14 days gap as possible. So you just resume the schedule, but for first 10 days, you try to be very vigorous to complete the 3 doses in 10 days.
Then,
okay.
sir, after post-exposure prophylaxis, if patient is not received the full course, receive 3 course or 2 doses, then stop. Again, re-exposure occurs within the 3 months. So what to do?
Now, this is a tricky situation. You are saying that patient was on the post-exposure prophylaxis, right? 3 doses
He
given,
has not, he
and
has
then
not
he was
completed.
defaulter, and
Yeah.
then he got bitten by the dog, right? So what do you do? if it is within 3 months, then I think because it is incomplete schedule, if it is fitting into your days, it is fine. Otherwise, you may go for the another schedule, but don't give immunoglobulin or monoclonal antibody.
Okay. Uh, very commonly we see children, they hide the bite. Like for example, they get a bite on the leg and they hide with the parent, and then after say 2 months they tell, "कि मम्मी मुझे को तो a dog has bitten." What do you do? A child has come to you after 3 months of bite, and now you don't know what is the dog and where is the dog, and they tell that it's not a street dog. How do you manage that?
So I think here, whatever time is lapsed between the bite and when you come to know, you have to treat it as it is occurred today only, now only. The problem occurs is we don't find the wound itself. Many times wound has been healed. So what you do, they say you have to infiltrate at the site of the wound if you know, right? And you start with infiltrate with monoclonal antibody if it is category 3 bite. Otherwise, if the category 1 or 2 bite, then I think we can give the ARV, you can start it post-exposure prophylaxis just like what we do, give it immediately after bite. So whatever time is lapsed, you have to continue, start it as if it is day zero.
Okay, so I think you have given very clear guidelines regarding rabies vaccine, and we hope that all the viewers they have got a clear idea how to use this vaccine. Next, now we come to HPV vaccine. Again, in India now at present we are having three vaccines. We are having
Chetan, sir.
yes.
So one question, sir. You told me that for the general practice, we are mainly we should give the IM injection. We are not allowed to give the intradermal. Your logic is why we should not actually we can't destroy the other. If from one family two baby was came same time, can I give the intradermal from one vial?
So technically speaking, yes, you can give it, right?
So
But
why not we are able to give? Why not we
yeah,
are
you can
allowed
give.
to do?
See, it is not the question of allowing. That's what I said. If you have suppose one family 5 member bitten, right? You can definitely, because ultimately you're going to divide the dose. Same 0.5 ml, you have to divide 0.1 ml each intradermal. You can give it. But I think it is because it is not in a short supply or nothing like that. Why you want to indulge into the techniques which is not been recommended by for practicing pediatrician?
Why not
Technically, you
recommend?
can give it.
Sir, we are allowed to give the BCG vaccine. So why
I know,
not
I
we
told
are?
you. I told the same thing.
Sir, देखिए, we are discussing clear guidelines. That is not an entry into controversy. Private practice, we should not use ideal, and that is final. It should be restricted to government hospitals. So I think we'll close the discussion here, and now we'll go to other vaccine. HPV vaccine. At present in India, there are three vaccines available for HPV. We are having two quadrivalent vaccine. We are having Sarsorvavac, and we are having Gardasil, and we are having nine-valent vaccine. My first question is that what is the efficacy of these vaccines? May it be quadrivalent or nanovalent? Are they useful? Do you have efficacy trials in India? Do you have studies in India? Are they effective?
Are effective. There is no question about in effectiveness because all these vaccines they have been proved beyond doubt it is effective. Right now, the question is when you talk about say bivalent vaccine, quadrivalent vaccine, monovalent vaccine, then what is the coverage? See, in India, when you say it is quadrivalent vaccine, almost 83% of cervical cancer is caught by 16 and 18. So that has been covered. And if you go to nonavalent, I think it will add 15% more cases of cervical cancer. So it will reach to up to 98% of the cervical cancer causing serotypes, right? So that is way it is going to be work. So quadrivalent, now it is available only two, quadrivalent and nonavalent. It is having good efficacy, very good efficacy for both male and female both, and it should be used according to the recommendation.
Okay, so I think this should be very clear that wherever these vaccines they are using across the world and they are very efficacious, they have almost wiped out cervical cancer in these countries like Australia and all European countries. So be very clear that these are very important vaccines. They are highly immunogenic. They act extremely well against these cancers. May it be cervical cancer or vulval, vaginal or anogenital warts and all. They are extremely effective. So please be very clear. Please use them in your practice. No, Doctor Chetan, we have.
Nanovalent vaccine above 26 years is not allowed, no? Nanovalent above 26.
We'll just discuss. So, Dr. Chetan, what are the guidelines for using Gardasil, Servavac, and Nanoval vaccine for males and female at what ages? Give some clear answers.
So I'll start with quadrivalent Servavac. Servavac can be given to 9 to 26 years, male and female both.
Okay.
Clear. Gardasil 4 can be given 9 to 45 years, females only.
Okay.
Gardasil 4, 9 to 45 years, females only.
Only female. Okay.
Yes. Gardasil 9, 9 to 26 years female, 9 to 14 years male. Now, so very clear. So
Yes.
suppose mother comes 30 years, there is no option. You give only Gardasil 4. If it is boy, you have option of nonavalent, you have option of Servavac, less than 14 years. If you have a boy 15 to 20 years, 26 years, only one option, Servavac. So that's very clear. Right? Now the question is of number of dosage required according to the age. Now, till now what we were following, 9 to 14 years, 2 doses, 15 years above, 3 doses, 0, 2 and 6, and 2 doses, 0 and 6. That is for any vaccine, right? Either it is a bivalent or tetravalent or nonavalent. Now, recently in 2025 guidelines, ACVIP, they have made one change. 9 to 14 years, rather 9 to 15 years, girls, quadrivalent vaccine, single dose is enough. Now that is a new thing which has come. And government has started the program where they are vaccinating girls between 14 to 15 years of age, single dose, right? It is in a campaign mode. So it is not, government is not giving to everyone, say 9, 10, 11 years. It's only giving 14 to 15 years campaign mode, single dose. But ACVIB endorses single dose for 9 to 14
What
years.
about the practitioner? What is for us?
So practitioners, we follow ACVIP. So now single dose 9 to 14 years, quadrivalent vaccine. Single dose for girls.
Boys,
Rest we continue same.
boys, same 2 doses.
Boys same. They have not
And-
mentioned about boys.
The
And
boy
the
name-
nanovalent vaccine.
Non-adult vaccine, they have not mentioned anything.
Okay.
They have mentioned for quadrivalent vaccine only.
Okay, so I think this different
Sir,
schedule
Chetan sir,
is
Chetan sir, one question,
Yes.
sir.
Yes.
Sir, just why not other are not changing? Sir is asking the question that what about the other vaccine? You are not giving the answer because the IAP guideline had mentioned 9 to 14 years single dose because government has started to give the 14 to 15 years of the age in the one dose. What IAP did earlier, once the government started, we approved that one. Why? Actually, that means government is very much well expert than other IAP. We follow
Okay.
government.
No.
Actually,
Listen
we
to
are
me.
recommending 2
I-
doses.
no. Dr.
When
Rahman,
government
SME.
started the one dose,
Dr. Rahman,
then
SME. Dr.
SIP thought that
Dr. Rahman, please. SME, please tell me the reason.
Just a minute. Dr. Rahman, you are saying that because the government has started single dose, we have just changed to single dose. No, that is not the case. ACVIP has taken enough pains to decide why to go for single dose. There are data which are available, Kenchi trial, Doris trial, Escudo trial, even our own the Indian trial. That also shows that with single dose also, there is enough of the efficacy data so that single dose is enough to protect if it is being given 9 to 14 years. Now, looking at the data, which is more for the females only, rather majority of data are with females, they have changed this, made a change, 9 to 14 years, single dose is sufficient, not because government has given.
Yes,
Okay, very clear.
Yes,
Sir,
so I think I just cut short. Dr. Rahman, please. There is enough immunological data indicating that one dose 9 to 14 is effective. That's why we have changed to one dose, not because government doesn't. I think.
Sir, good evening. Can
close
I
that.
add something?
Yes.
Sir, I heard that one single dose is enough to prevent cervical cancer. But for preventing HPV infection, you will need to give three doses. Is that correct?
3 doses is
No,
not
ma'am.
recommended below
No,
14
ma'am,
years.
we don't differentiate between cervical cancer and HPV. When we talk about
Okay.
this vaccine, it is not cervical cancer vaccine, it is HPV vaccine. That is very clear, right? So when we talk about vaccine, there is HPV prevention only. But the data are for these girls between 9 to 14 years, Definitely, there are other also, but majority data which is only for females. And when we are talking about females, it is cervical cancer at the majority important. That's why we are telling HPV vaccine single dose 9 to 14 years girls.
Yes,
That's what
so
is
I think
changed.
so. Just remember these all things because the way the vaccine is licensed and the way the permission is given. That's why there are different ages and different for sexes. But this is basically why the way the vaccine has been licensed and the trial has been done. That's why there are restrictions that you cannot give from 9 to 26 and beyond that. So these are all licensing requirement and these are there in the package insert. So please follow that. Now, last question
I
for
think, sir,
HPV vaccine.
let me just correct it. Package insert will still continue having 2 dose or 3 dose, right? Because this is a ACVIP recommendation, and that's why it is we are being guided by ACVIP that single dose is sufficient. I think that has not been changed yet,
Okay,
as
okay.
far as my information.
Oh, okay. Now the last question for HPV is that suppose a child who has received at the age of 16 years one first dose and then he comes late or yes he's a defaulter. What do you do? His second dose is late or third dose is late. What do you do?
So when we say it is after 15 years given, so we know that there are 3 doses to be given, 0, 2, and 6, right? Now he has not come for the, she has not come for the second dose. So you start from where you left. You give dose, and the third dose, second and third, you keep a gap of at least 3 months or 12 weeks. That is important. But you
Okay.
finish the 3 dose, you don't restart, but you give 2 more dose and finish the schedule.
Okay, so again, very important is that you don't have to repeat. He might come after 6 months or 1 year or 2 year. If the first dose he has received, that will be counted, it will be valid, and then subsequently you have to complete that. Thank you very much. I think we have cleared regarding HPV vaccine. Now we'll take PCV. Now not much time is left. We'll take quickly two more vaccines, PCV and flu vaccine. Now in PCV vaccine, we are having three important vaccine in India. We are having one tetravalent vaccine, which is pneumococcal. We are having third variant vaccine, which is Prevnar, and one protein vaccine, which is Nivovax. Now there are different serotypes being covered, and there is a lot of confusion which vaccine to use. Now, first question to Dr. Chetan is that what is difference between direct and indirect? Because a lot of confusion is there, direct and indirect. What is the difference between direct and indirect protection? Which is better?
This question is cannot be answered that simply the way you have asked
Quickly,
that simple question.
shortly.
See, when we talk about direct and indirect protection, we majority time we talk about 6A and 6B. We know that because whatever we have vaccine we have, either PCV 10 of serum that is having 6A, right? PCV 13 Prevnar having 6A. PCV 14 Nubivax doesn't have 6A but is having 6B, right? So the discussion is always going on. Direct protection against 6A is better or 6B giving a cross protection against 6A is sufficient. Now, in general, WHO has said that direct protection always better, right? At the same time, 6A and 6B, they are both vaccine only difference of one amino acid connection. So it is almost simple, right? It is similar. So what they found that in US when PCV 7 was given, the 6B was there, but 6A was not part of PCV 7. And what they found in those vaccinated, 6A incidence has also gone down 76% efficacy. And later on, it found almost 90%. But so this was an indirect protection offered by 6B containing vaccine against 6A. So that's why the discussion came that direct protection is equal to indirect protection. Now, what is the difference now? Say maybe 90% and 100%, that's not a much difference. But when you talk about the nasopharyngeal clearance, that is always better with direct. So same vaccine. So 6A containing vaccine definitely gives better effect on nasopharyngeal carriage. Now 6A gives the cross protection against 6B and 6C. 6B gives cross protection against 6A, but not 6C. So if your country is having 6C, which is in a good number, I think 6A containing vaccine has to be kept. So 6B, there is no question, it has to be there. But 6A, you may err on the side of getting cross protected, but always better is direct protection. But still, if you are compromising on something and getting something, you can definitely do that. So that is in
So
nutshell.
yes, so the consensus is that direct protection is always good as compared to indirect. Direct protection is important for nasopharyngeal carriage because that will cause herd protection, and it will good for mucosal disease. All otitis media and mucosal pneumonia, they are better protected by direct. So I think if whenever you have a vaccine which is giving direct protection, it is the vaccine of choice. Now, how important are 23F and 33F? Because a vaccine which has introduced these two new serotypes, are they important in India? Like, should we consider them because they are emerging serotypes? They might come when after some years when you start using PCV so much. So, are they relevant for today?
This is additional two serotype 22F and 33F, which is part of PCV 14, right? Now we know that there is the issue which is happening is serotype replacement. When you have, say, 7 serotypes and other serotypes which were not part of the vaccine, it comes up, then numbers are increasing. Similarly, if you are using 13, then others. So looking at that in US, UK, where this vaccine has been already been given in the national distribution for a long period of time, they found UK, US, there is a serotype replacement. There is emerging serotype. These two serotypes, 22F and 33F, are emerging serotype. So at present, definitely it is not been found much in our country. But definitely once we are getting that PCV coverage very good, maybe because now it is government schedule and it is crossing that 90% herd immunity is developing, we may have. As of now, it is not significant. So that is my say. Yes, they are going to, because now whatever next vaccine, PC 15, 20, and all, they are having 22 and 33F. So definitely they are going to be important. But as of now, it is not there. So that is
Yes,
what my say.
so very clear answer. 22 or 23, they are not important. At present, we don't know what is going to happen in future, but at present, they are not important. Last question for PCV. What is the
We can't
importance
say
of three?
important, sir. We can't say not important, but at least we can
Right
say
now,
incidence.
right now they are
Ah,
not important. Right now there are very few cases of 23. So that
yes.
if you tell that if you see the serotype, they are almost negligible. So if you try to select a vaccine to given for today, I think they are not relevant for today. They
So
might come
these
after
are
some
the
time.
recommendations which are dynamic. I'm telling you.
Yeah, I
We may
understand, but
maybe
yeah, I understand, but
yes,
we are talking about today. Now,
correct.
one
Okay.
vaccine, 10 valent doesn't contain 3, 4, and 18C. What is the rationale? Just in one or two words, is it or they are not important? 3, 4, and 18C.
So the Serum Institute people, they bargained 6A against 3, 4, and 18C. Simple. Because they wanted a vaccine which should be cost effective, they removed these three. Why they removed three is three, 4 and 18C, very insignificant number, very less number in our country. So India specific they have made epidemiologically correct vaccine. But they tried to cover 6A because 6A is good number and it gives cross protection 6B and 6C. But at the same time, now 3 is very important, serotype 3. Yes, it has to be there in part of any vaccine. But unfortunately, serotype 3 is very difficult to crack. Even with Prevenar, the data, even WHO has accepted that it is not working as it should against serotype 3. So that's why 3 becomes negligible by virtue of its property. 4 and 18C not much what they are getting by getting 6A and at the same time making it cost effective. So when you talk about pneumococcal vaccine, ultimately vaccination is important because 10 is also good, 30 is also good, 14, even 15 is going to be good. But whatever vaccine is available and it is feasible and patient is ready to take, we should vaccinate them because hardly much of the difference as far as individual practice is concerned.
Okay. So I think you have given a very good important answer, but serotype 3 is a very serious serotype and it causes very severe disease. So even if it is causing some protection, I think if because all future vaccines they've got serotype 3. Only you can take the example of 10 valent serum. Otherwise, every vaccine has got serotype 3. So I think excluding serotype 3 doesn't make a sense. It must be there. So we have got three important vaccines: 10 valent serum, we have got 13 valent Pfizer and 14 valent B. Out of after your answer, I think again serotype the PCV 13 it scores because it contains all the serotypes which are present currently in India. I think if first preference should be with 13, second I think will be there is a
That
very close
that
fight between
we
two.
can't compare like that, sir. It is not, we can't compare head to head like that because no vaccine has been trialed head to head. But yes, we can say because serotype 3, even if it is there, what he has given? Nothing, sir. So we can't just take it that way, that serotype 3 is covered, so it is good. It has not worked very clearly. So that's fine. We can put it that particular sentence in between
For your
that you
practice, what you
use
will do? For your
13,
practice,
14
what
or
for your practice, what you will do? What you will do
I
in
use
practice?
I use all three. I use all three in different population.
How can you use all three in a child has come to you? Which
Depending
practice you
upon
use?
Sir, depending upon the things like, suppose if you have a patient who is not affording, and I would definitely like to go for PCV 10, 100% I'll go.
Okay.
PCV 13 and 14. Suppose somebody is given 14, I'll continue with 14. 13, I will continue with 13. So nothing, no vaccine is bad as compared to others, but definitely there is some subtle differences.
Okay, so Dr. Chetan, thank you very much. I think we have exceeded time by 5 minutes. Today, it has been an excellent insight from you, given some very clear answers regarding 4 important vaccines, and I think the viewers must have been benefited by your wisdom. And we hope that whatever information you have got today in this particular CME, you will be using this vaccine in more effective and in a more clear manner. Let us hope. If there are any more questions, because we cannot, because the time is already, we exceeded the time. So if there are any more questions, please you can either direct to Dr. Chetan. We'll share his number to you, and he'll be more than happy to answer all the questions. Thank you, Dr. Chetan, for an excellent insight. Thank you very much.
Thank you, Dr.
Over to
Chetan. It
Dinesh.
was like icing on the cake, basically for the general pediatricians. I think we have attended so many vaccinology lectures, but this was excellent. Now all the doubts are clear for all the members. Thank you very much, and thank you, Rawat sir, for moderating the session. I think these two stalwarts have done a job very good. Thank you very much, and thanks to
And good to
everyone
see the
for
vaccine
attending.
experts. Good to see vaccine expert Dr. Jaideep, Dr. Surendranath, everybody is
Yeah, Dr.
there. I
Jaideep is
think
also there.
I
Yeah, welcome,
stand
Dr. Jaideep.
I
Yeah,
stand corrected for whatever information shared because all these are vaccine expert, national vaccine experts. So
yes,
we are
yes,
interacting
yes.
very frequently.
So we
Thank you
are
so
very,
much everyone for
very,
being there.
yes, we are very fortunate that all people they have joined this webinar today. Thank you very much for joining this
Thank
webinar.
you. Good night, Chetan sir, and